session, I'll invite Dr. Sonu Goel for his oops moments with phakic lenses. And I see that our next session, people are here. We'll just try to finish it fast because we got 5-10 minutes late, but we'll finish in before 10.
Thanks, Gaurav, for making me part of this course. So I think there is some oops with the AV team. Huh? Can we have the AV plugged in, please? So I think when we talk of the ICL surgeries, the biggest challenge for, yes, we are placed. So oops in ICL surgeries. So I think when you're talking of refractive surgeries based on ICL, the biggest problem or the biggest oop would come either from the sizing or from the surgical technique. So we all know that we are very, very cautious for avoiding these conditions when you have an excessive vault or a very low vault. And here is one of the patients who came to us. This is a 26-year-old female with a refractive error of -4 with -0.5 of 180. The keratometry readings, the Phakic, the anterior chamber depth, close to 3.3. What is more interesting is the white to white, 11.65. And both the eyes. The vault prediction by the Lasso formula. So we use an IL Master 700 here, and the predicted vault using an IL Master 700 using an ICL size of 13.2 came out to be close to 724 and 729. So we sent the data to the Star Surgicals, and with their OCOS, they came up again with the same size of ICL 13.2. And so we went ahead and we took this patient for the right eye, and this is how this was 13.2 ICL, and very carefully we use the sponge here, avoiding any touch to the delicate lens, and specifically for low diopters, the optics are very, very thin, so care should be taken to avoid pushing, pulling, or trying to catch in the center. This is a good trick to put in viscoelastic, avoiding air. And then calibrated incisions, so 1.1, 2 side ports we do, and the size of the main incision always has to be 3 millimeters. I don't do a wound assisted, always advocate that the injectors should be slightly within the anterior chamber so that it gives a good control, and at times you can rotate. So looking into the 3 holes there, just this lens was pushed. I have an access to an intra-op OCT also. So once this lens was in place, we took this patient day 1, as we routinely do in all our patients, for the vault measurement. And to our surprise, the vault came out to be 1330. So that was quite a surprise. But luckily, the angles were open and the pressure was normal. Now, this was a toric lens. Now, the trick was that what should be done for the other eye, which is to be taken the next day. So this is where we take this patient, and we are doing the second eye on the second day, and we are keeping in, quite worrisome that the vault might be high. So we push in viscoelastic, try to settle the lens, but this time I have an access to the intra-op OCT, and so keeping in mind the vault to be nearly the same in this patient, because we tried to get one lens lower, that was not available. So what we do is we rotate the lens. This is a non-toric lens, and we try to rotate this lens vertically. So just see, from close to 900 intraoperatively, it came down to 700 with this intraop OCT. So rotation with the non-toric lens, putting the lens vertically, might help in getting the vault. See, now there's a reduction in the vault, which is close to 700. And this is the vertical orientation, as you see the 2 holes, and on day 1. So we were able to achieve adequate vault in the left eye, which was close to 973 on the anterior segment OCT. So sizing is very, very crucial, and what is more important is this table that I want to bring in, that with the star, the moment the white to white shifts from 11.64 to 11.65, the size of the ICL shifts one size up from 12.6, 13.2. So I think this was one of the major contributors for the refractive surprise or the wall surprise that we have. So, is there any way to predict the vault? Yes, we have a lot of vault prediction formulas, the Lasso, the Reinstein, the KS, the NK43. Routinely, what we use is Lasso, and we also recommend all of you to use this formula. A very simple formula. Online you go, feed in the patient data. What is important is a refractive sphere which has to be fed in. Then you feed in the anterior chamber depth. So you can use either the data from the MS39 or you can use the data from the ILMaster 700. So we feed in the ACD data here. After the ACD comes the lens thickness. Then comes in the white to white on the ILMaster. Then you feed in the K readings and both the K and the K1, K2 readings. This is the ILMaster, the central corneal thickness, and then you have the pupillary diameter, and then this will give you the vault with different sizes of the ICL. So for example, if you have an ICL of 13.2 size, you will have a predicted vault of 773. So I think this works very well and helps in avoiding those outliers, maybe a small, maybe a low or a high vault. Recently, I think thanks to Gaurav who shared us this wonderful tool which is called, with your permission, Gaurav, I'm using this here, and this is a wonderful tool, ICL calculator, and this is actually an online calculator which helps you in giving you an adequate size and predict the vault. The beauty of this equipment is this is available online freely, and you can change the equipment that you're using. For example, if I use an ILMaster 700 here, it will actually give you what is the white to white adjustment and what is the anterior chamber depth measurements that you can change or that are required. For example, an eye trace, see the calibration white to white and the anterior chamber adjustments are calibrated. And then you can feed in the right and the left eye data. You can calculate and take a printout of the required size of the ICL. So I think all in all, the adequate size calculation is very important when you're dealing with these phakic lenses. So thank you.
Thanks a lot, all the speakers, and thank you for being patient from the next session. And we'll hand over the stage to you right away.